name is Xin Gao, and I'm a medical oncologist at Mass General Cancer Center, where I focus on treatment of cancers of the urinary tract. I'd like to offer some thoughts on some of the research recently presented at the ASCO annual meeting in June 2021, focusing on 3 related analyses that came out of the phase 3 JAVELIN Bladder 100 clinical trial. As a brief background, JAVELIN Bladder 100 is a randomized phase 3 trial evaluating the use of maintenance immune checkpoint inhibitor Avelumab in patients with unresectable, locally advanced or metastatic urothelial cancers who did not have disease progression following completion of first-line platinum-based chemotherapy. So that's either cisplatin gemcitabine or carboplatin with gemcitabine for 4 to 6 cycles. This study enrolled 700 patients who were randomized 1-to-1 to either best supportive care alone or with the addition of Avelumab IV every 2 weeks. The trial was previously presented at ASCO in 2020 and published in the New England Journal of Medicine, showing a significant disease-free benefit as well as overall survival benefit with maintenance Avelumab with a median with a hazard ratio of 0.69 and median overall survival of 21.4 months versus 14.3 months. This study led to the approvals of maintenance Avelumab by the FDA as well as the EMA. Now this year, 3 post hoc analyses of the JAVELIN Bladder 100 trial were presented at the ASCO annual meeting. I think the most interesting and clinically relevant was the analysis of clinical and genomic subgroups presented by Dr. Tom Powles. In this analysis, they first looked at the primary location of the tumor, whether it was upper tract or lower tract primary. And overall, maintenance of Avelumab appeared to be beneficial to patients regardless of the location of their primary tumor. The second evaluation in this analysis was regarding the type of advanced disease, whether it was metastatic or unresectable locally advanced disease prior to chemotherapy or lymph node only disease post-chemotherapy. And again, it appeared that maintenance of Avelumab benefited patients regardless of the type of advanced disease that they had. The third subgroup looked at patients who had PD-L1 positive tumors and received first-line carboplatin gemcitabine. And again, the hazard ratio for overall survival here was 0.67, which was on par with the overall population, and showed benefit with maintenance Avelumab. And finally, molecular subgroups were analyzed for 4 groups of characteristic gene expression profiles based on work from the TCGA. So that's basal squamous, lumino-infiltrated, and luminopapillary subtypes. And overall, maintenance of Avelumab appeared to be beneficial regardless of the molecular signature subgroup, with the exception of maybe the lumino subgroup, which had a hazard ratio of 1.01 for overall survival. But this included a rather small number of patients in this histologic subgroup, or excuse me, molecular subgroup. And notably, the basal subgroup did have higher PD-L1 expression and more CD8 positive cells in the tumor area than other tumor types, while the lumino subtype of tumors had relatively higher APOBEC mutagenesis gene signatures. So I think this clinical and molecular subgroup analysis of JAVELIN Bladder 100 does support the use of maintenance Avelumab further in advanced urothelial carcinoma patients who had not progressed after first-line platinum-based chemotherapy, really regardless of any clearly discernible clinical or molecular features, benefiting more or less. And perhaps a lone exception is this lumino subtype group of tumors, where additional studies, I think, are needed given the relatively small numbers of patients in this post hoc analysis. The second post hoc analysis that was presented at ASCO this year on JAVELIN Bladder 100 was a poster by Dr. Petros Grivas and the investigators evaluating the time to end of next-line therapy in the randomized trial population. The endpoint here was time from randomization until the end of next line treatment received after first progression, either due to death or discontinuation of treatment. This time was significantly longer in the randomized population, with a median time to end of next line therapy of 14.8 months compared to 9.2 months in favor of maintenance avelumab. This was similar for patients with PD-L1 positive tumors as assessed by the Ventana SP263 assay, with a median of 18.1 months versus 9.0 months, again, favoring maintenance avelumab rather than best supportive care. And then finally, the third post hoc analysis of JAVELIN Bladder 100 was a poster by Dr. Shrikala Sridhar and the investigators looking at the treatment-free interval from the from the last dose of chemotherapy to the start of maintenance avelumab or best supportive care alone on the study. This ranged from 4 weeks to 10 weeks on the trial, and the conclusion was that the maintenance avelumab was, again, beneficial regardless of the treatment-free interval, which was characterized as between 4 to 6 weeks versus 6 to 8 weeks and versus 8 to 10 weeks. So I think the summation of these 3 post-hoc analyses really adds further support for the use of maintenance avelumab in this population of patients with advanced urothelial carcinoma who did not progress after first-line platinum and gemcitabine-based chemotherapy.